Bismillah ar-Rahman ar-Rahim. Hello, my dear friends and my dear colleagues and fans everywhere. This is Professor Dr. Tarek Ali. This is to continue my clinical topics series on live presentation or online live presentations. Today I will speak about, as I promised you, about the acute headache in clinical practice. In fact, the headache is a very common clinical presentation in our daily life as physicians. It's commonly met with in the outpatient clinics and also in the emergency departments. As we all know, acute headache is a sudden severe headache which attacks the individual. And it develops quickly within seconds or minutes, and it might evolve and progress or be associated with other clinical manifestations. Acute headache has many classifications and has many types. There are maybe more than 150 types of acute headache. And the underlying causes are variable, that is, the etiopathogenesis is variable. There is a lot of controversy about the classification of headaches, but I will talk about the most commonly used classification of headaches in clinical practice, which is the classification of acute headache into primary and secondary. And acute headache, in fact, which is the sudden severe headaches, acute in onset, affecting the individual, it might develop de novo or might develop on top of chronic recurrent headache. So the same causes of acute headache might also cause chronic and recurrent headache, or what we call also another category, the episodic headache. Acute headache, as a clinical presentation, as I mentioned, it might be one of two types. Primary headaches, this is one category, and secondary headaches, the other category. Let us talk first about the primary headache, which is the first category. And primary headaches include three main types or classes of headaches, which are the tension headache, and the migraine headache, and the cluster headache. The tension headache, it is more commonly met with in patients under stress and suffering from chronic tension, plus or minus an anxiety, and plus or minus also a depressive illness. So it is related to stress, and it might be related to acute plus or minus chronic stress. So this is usually met with, this is in fact one of the commonest types of headaches in clinical practice. Most of the cases, at least 50% of acute headache presenting to us and the chronic recurrent headache presenting to us in clinical practice is related to stress. And we call it tension headache. It might be chronic with acute exacerbations. So tension headache, and this is one. Number two is the migraine. Migraine, it's a vascular headache, as we all know. I will not speak in details about migraine, because migraine, to talk about it, it needs one presentation by itself. But I will rather talk quickly about it. We all know that it is a type of vascular headache, and it is in fact the most common type of vascular headache. And it usually occurs in females, and is affecting women more than men, maybe 3 to 4 times more than in men. It affects women more. And it usually presents since the young adulthood, or since early in life, and then it progresses or continue throughout the rest of life. So we might see it in young women, in middle-aged women, and in elderly women. But it usually starts early in life, as I mentioned, maybe even since childhood. And it might be related to hereditary or genetic factors, as well as to acquired factors. It's an inflammatory brain disease, which is associated with vascular changes, first with vasoconstriction of the cerebral vessels, and then vasodilatation of the cerebral vessels with the acute painful episode. And so its pathobiology is inflammatory and vascular at the same time. So it's a mixed inflammatory vascular disease in which many molecules and neurotransmitters and receptors are involved, among which is the calcitonin gene-related peptide receptors, and also serotonin and other receptors and neurotransmitters in the brain. But the result of all of these factors will be reflected on the vascular changes. First, the vasoconstriction associated with clinically with the aura, which characterize the common and classic migraine, because we all know that migraine passes through 4 stages or 4 phases: the prodrome, and then the aura, and then the episode, and then the post-ictal or the post-pain phase. So there are 4 phases: prodrome, aura, the acute headache or the painful episode, which is the actual migraine when it attacks the individual, and then after the pain, the patient goes into what we call post ictal and post-pain phase with different clinical manifestations like lassitude, tiredness, confusion, irritability, somnolence, etc. So it is a vascular headache, and it is throbbing, and it's most commonly seen in women, and usually preceded in the classic type with and in the typical attack, where it's preceded by aura in the form of visual manifestations, visual blurring, flashes of light, sometimes nausea, vomiting, changes in heart rate, tendency to sleep, déjà vu phenomena, other mental manifestations related to the vascular changes, the vasoconstriction, and then followed by the vasodilatation. When the vasodilatation occurs, the pain, the acute pain of migraine, which is classically throbbing or bounding in nature because of it, or pulsating in nature, it is described as throbbing or pulsating in nature or bounding in nature. Something is binding inside the skull due to the dilatation of the blood vessels. So it is pulsating or throbbing, the classic character. The type of the pain is very important. The type of the headache is very important in the analysis of headache. So, and then this is the acute attack or the pain follows, and then after that the pain, of course, it has variable duration from minutes up to hours, and it may be repeated and recurrent the same day or several days per week before it remits and enters into the episodic or the chronic phase after that. So this is migraine, and as I mentioned, there are many types of migraine. There is classic migraine, common migraine, complicated migraine associated with ophthalmoplegia. We call it ophthalmoplegic migraine. We have also complicated with focal neurological deficits and motor deficits. We call it hemiplegic migraine, and we have also a typical migraine presenting with features outside the skull, like chest pain sometimes, like upper abdominal or epigastric pain, or vomiting, or this is a typical migraine. We have cephalgic migraine, or migraine without cephalgia, or cephalalgia, that is without pain in the head. So migraine can present without pain. Yes, it is a very, very rare type. We call it the cephalgic migraine. So the absence of pain does not exclude the migraine, but it is a very rare type of migraine without pain, cephalgic migraine, or atypical, and it's considered as one of the categories or the types of atypical migraine. So as we see, migraine has many clinical presentations and many types, but all fall under the heading of migraine, which is a vascular headache, because the underlying pathogenesis is related to vascular changes. Another type, which is vascular also and is one of the primary headaches, is the cluster headache. And the cluster headache is more common it is the opposite. It is more common in males than in females, and it comes in clusters, usually with pain in the eye or around the eye, and it may be radiated to the frontal region, frontal headache, and usually associated with maybe eyelid drooping, that's fall of the eyelid, maybe also with pupillary changes in the pupil of the eye on one side, and it may be on one side or on both sides, and it may also be associated with eye reddening. The eye becomes red, maybe lacrimation, that is increased tearing from the eye, maybe also with rhinorrhea, that is increased nasal discharge. And these clusters usually maybe it occurs in clusters in the same day before it appears, but it might be recurrent later on. And this also type of headache is vascular in origin, and it is one of the vascular headaches. The second common vascular headache after migraine. So migraine and cluster headache. But this is a disease, and this is another disease. But they are all in the vascular headache category, or vascular headaches. So this is in short, the primary headaches: the tension headache, the migraine headache, and the cluster headache. Then we come to the secondary headaches. The secondary headaches also, they constitute many of the or a large group of cases presenting with acute headache. The secondary headache groups or categories include those related to vascular also changes, as what happens, for example, in patients with intracerebral hemorrhage. Intracerebral hemorrhage is a vascular cause of headache, and it might present with acute headache. Of course, with other focal neurological manifestations, motor deficits, sensory deficits, speech problems, gait disturbances, and of course disturbance in the level of consciousness, from drowsiness passing through stupor, semi-coma, and coma. So this is hemorrhage inside the brain, or intracerebral hemorrhage, whether in the parenchyma of the brain or in the ventricle of the brain, intraventricular hemorrhage, or parenchymal or parenchymatous cerebral hemorrhage, whatever the type, they are all cerebral hemorrhages. Also, in patients with ischemic stroke, they might present with headache. So this is another also vascular disease in the brain associated with headache. And of course, hemorrhage and ischemic stroke constitute what we call cerebrovascular stroke, a specific group of cerebrovascular disease, which is common because it is met with in patients at high risk, including those with diabetes or hypertension or the metabolic syndrome. They are all at risk of cerebrovascular disease, including hemorrhagic stroke and ischemic stroke. So stroke is cerebrovascular disease with different clinical manifestations. One of the manifestations is acute headache, so cerebral hemorrhage. Also, another category is, or another cause of secondary headache, which is vascular also, is cases with subarachnoid hemorrhage. And subarachnoid hemorrhage causes what we call thunderclap headache, which is sudden severe headache, and it's usually described by patients as one of the most severe headaches described or met with in life. The thunderclap headache, because it attacks suddenly the individual, and it might be associated with nausea and vomiting and collapse to the ground. And usually it's related to the occipital region, and then become generalized, and with loss of consciousness, plus or minus vomiting, which may occur once at the onset, and then the individual falls to the ground. And this is subarachnoid hemorrhage, which is most commonly related to an arteriovenous malformation or cerebral aneurysm rupturing into the subarachnoid space and causing the subarachnoid hemorrhage. And here the subarachnoid hemorrhage is different from the subdural hemorrhage. Subdural hemorrhage is more commonly in patients who get multiple falls, like elderly with pathologists who get syncopes or syncopal attacks, drop attacks. They might, especially in alcoholic people who are drunk, who are losing consciousness on several occasions. Their head might be hit to the ground or to any object on several occasions, and they gradually get a type of headache related to chronic subdural hematoma. Chronic subdural hematoma related to alcohol and other predisposing factors and recurrent falls in the elderly. This chronic subdural hematoma causes another type of headache, usually chronic headache, because it is gradually developing. This is chronic subdural hematoma. Acute subarachnoid hemorrhage is different. It causes thunderclap headache, very acute, sudden, severe headache, which attacks the individual, associated with coma and vomiting, maybe at the onset, maybe at least once. The person vomit and then falls to the ground with sudden severe headache. This is the subarachnoid hemorrhage. Another vascular cause of secondary hemorrhage causing acute headache is acute headache related to dural venous sinus thrombosis. That is thrombosis not inside cerebral veins, inside the sinuses at the surface of the brain. So we call it dural venous sinuses because they are in the dura mater of the brain. So dural venous sinus thrombosis due to, for example, like what happens in hypercoagulability or thrombotic states, which is a blood disease with increased tendency for coagulation. Among the neurological manifestations in such patients with hypercoagulability is tendency for cerebral venous sinus thrombosis. Cerebral or cerebrovenous sinus thrombosis, like dural sinus thrombosis, presents with brain edema and also will present clinically with acute headache, especially with acute thrombotic episode in the dural venous sinus. So cerebral hemorrhage, ischemic stroke related to thrombi or emboli, cerebral hemorrhage, subarachnoid hemorrhage, dural venous sinus, these are all vascular causes. Also, to finish the vascular causes, we have to speak about the hypertensive syndromes and the hypertensive emergencies with acute headache, namely patients who get sudden severe rise of blood pressure, systolic above 180 or more, and diastolic more than 130. They are liable to get neurological complications, including hypertensive encephalopathy with cerebral hemorrhages and cerebral edema and with papilledema and sudden severe headache associated with the, if not properly, and also drowsiness or disturbed level of consciousness due to the cerebral edema and the petechial hemorrhages in the brain. In hypertensive encephalopathy, we call this acute hypertensive encephalopathy. So this is related to rapid, sudden rise of blood pressure, breaking the limits of the cerebral autoregulation, cerebrovascular regulation, the physiologic regulation. So the leakage from the cerebral vessels, cerebral edema and the hemorrhages, this is the underlying pathobiology of hypertensive encephalopathy. Cerebral edema and minute hemorrhages causing the clinical features. One of the clinical features is the acute headache which such patients feel. Hypertensive encephalopathy also in patients with malignant hypertension, with papilledema and acute renal failure. It might also be associated with acute headache. And then come the ultimate, if not properly controlled, the hypertensive encephalopathy or the malignant hypertension, the patient will get hemorrhage inside the brain, that is a stroke. So these are all related to hypertensive, what we call hypertensive urgencies and emergencies. They might present with acute headache also. And they are considered among the secondary or causes of secondary headache. We have other causes of secondary headache, including the, of course, medications, and this is what we call, sometimes we call it medication abuse headache. Medication abuse headache or rebound headache, and this is related to the abuse of medications more than 3 times per day or more than 4 to 6 times per week. Patient, especially the medications used for acute migraine and acute headache, the patients might experience a rebound headache with worsening of the headache, not improvement of the headache. We call this medication abuse headache or rebound headache related to the use of over-the-counter drugs for acute migraine and acute headache, the rebound headache. We have also what we call hormonal headache, like the headache related to hormonal changes, and this is more common in females or in women, related to consumption of contraceptive pills. So the pills, especially that containing norgestrel and progesterone, they might also have increased incidence of headache related to the fluctuations of female sex hormones, especially progesterone and estrogen, and the use of pills. So pill-related headache or hormonal changes related to menstruation. We can get exacerbation of headaches and exacerbation of migraine and premenstrual headache without migraine as a different category related to the hormonal fluctuations in menstruating ladies. This headache may precede menstruation or occurs with menstruation or after menstruation. So this is hormonal headache. Or may be related to pregnancy also. So the headache associated with pregnancy is one of the classes of hormonal headache. So pregnancy, menstruation, contraceptive pills are all the most common examples of hormonal headache. And then, so I talked about the hormonal headache, I talked about the medication abuse or the rebound headache, and then also I have to talk about the what we call caffeine headache. And this is the headache related to the consumption of caffeine or caffeine-containing medications or substances. This is called the caffeine headache. So caffeine headache, hormonal headache, and the drug abuse or rebound headache, these are all also examples and types of secondary headache which we should observe. Also, the headache which is met with in patients with meningitis or infections. Infections can cause headache by different mechanisms, and this is one of the common causes of headache in clinical practice. Whether these infections are systemic outside the brain, like the headache associated with flu or with viral respiratory infections in general. There is headache, there is backache, there is myalgia, there is chest pain, there is headache. So as a part of a systemic viral disease or systemic viral syndrome, as met with in patients with viral respiratory infections, the commonest is flu and the influenza and the other viral syndromes producing flu-like illnesses. They like COVID-19, like other viral syndromes, they might be associated with headache. And this headache is not related to an infection inside the brain. It is systemic infection causing secondary headache. And this is related to the toxins. This is related to certain cytokines which disturb the brain. This is related to the fever, and so many febrile illnesses are associated with headache. Even if they are not localized to the brain, they are systemic illnesses with fevers. Or these infections might arise in the brain. So the infections within the brain causing fever and the headache, like for example meningitis and meningoencephalitis. Meningitis, whether bacterial meningitis, and here the patient will have acute headache, vomiting, nausea and vomiting, photophobia, stiff neck, meningeal irritation signs. This is more common in bacterial or septic meningitis, especially meningococcal meningitis. So there is acute headache, there is nausea and vomiting and stiff neck and photophobia, avoidance and fear of light, and also may be associated with convulsions, may be associated with focal neurological deficits sometimes, and classically associated with meningeal irritation signs like positive Kernick sign, Prozinski's sign, Prozinski's neck sign, Prozinski's leg sign positive. So there are meningeal irritation signs characteristic of septic meningitis. Or the meningitis might be viral, for example, or and there are many causes of viral meningitis, and or maybe fungal or protozoal, or what we call aseptic meningitis in general. So meningitis and encephalitis, they are also common of acute headache, and usually they are associated with fever, that they are febrile illness. So the presence of fever with headache can help in the differential diagnosis of the underlying etiology and underlying pathobiology. So this is the infections as a cause of acute headache, whether in intracranial infections or systemic infections with causing acute headache as a part of the systemic disease. As I mentioned, especially in infections, viral infections. So this is another cause of secondary headache. Then we come to other less common causes of headache, like the what we call the benign intracranial hypertension or pseudotumor cerebri, or idiopathic intracranial hypertension, which is more common in obese middle-aged women, and they present with features of intracranial hypertension without the presence of tumor. That's why, but because they present like a tumor without the presence of cerebral pathology or tumor or cerebral dysfunction, we call it pseudotumor cerebri. There is increased intracranial pressure, there is increasing headache, progressive visual loss, and progressive papilledema. But on CT scan and on MRI of the brain, there is no intracranial space-occupying lesion. There is no intracranial neoplasm. There is no tumor. That's why we call it pseudotumor. It is intracranial hypertension without space-occupying, real space-occupying pathology, without a tumor. So we call it idiopathic intracranial hypertension or pseudotumor cerebri. And it also might present with recurrent acute headaches, with progressive headache, progressive visual loss, papilledema on fundus examination. That's why fundus examination is very important in any headache patient. CT scan is very important in any patient with acute headache, and lumbar puncture comes later on after that. That's why after taking good history and thorough physical examination, history is very important, and sometimes diagnostic, especially to reach to the diagnosis of migraine. Migraine and the cluster headache are diagnosed, and tension headache, which are primary headaches, they are diagnosed from the history only. No need to do further investigations. From the history and then physical examination to exclude physical or systemic disease, you can reach to the diagnosis of primary headaches, tension headache, migraine, and the cluster. Because the descriptive nature and the details of the headache, the character, the type, the duration, the severity, the history, the acuity, this information we get it from, or we, as physicians, we get them from the history taking. So from the history is very important, to sit with the patient, to talk with the patient, ask the patient about the onset, course, duration, associated symptoms, presence of aura, manifestations, any vomiting, any visual blurring, these are all important. History taking and the history details of the headache and the other neurological features, consciousness, motor problems, sensory problems, the cranial nerve problems, speech problems, gait problems, these are all from the history. And then the physical examination for the speech, for the gait, for the detailed neurological examination, motor system examination, sensory system examination, cranial nerve examination, cerebellar examination, examination for the gait and speech evaluation, and so these are all history and physical examination. Then we come to the investigations. Investigations help to exclude secondary causes of, like vascular causes, like stroke. We have to do CT scan of the brain, MRI of the brain to detect stroke, to detect venous sinus thrombosis, to find the subarachnoid hemorrhage. So these are detected on especially the vascular problems of acute headache, the cerebral hemorrhage, the subarachnoid hemorrhage, the ischemic stroke. They will be or can be detected and diagnosed on CT and MRI of the headache, of the head. So here the value of CT and MRI. Also, to do a bedside fundus examination to detect any papilledema, which denotes an intracranial hypertension or elevation of the pressure inside the skull. To diagnose brain tumor, to diagnose, as I mentioned, idiopathic intracranial hypertension, the pseudotumor cerebri, which as I just mentioned, and I will talk separately about the pseudotumor cerebri in a separate live presentation, inshallah. So these are all, but these are or can be picked up from fundus examination to detect the papilledema. And then after that we can do lumbar puncture to detect infections, meningitis, bacterial meningitis versus viral meningitis. There are changes in the chemistry, in the type of cells in the CSF, in the character of the CSF, in the appearance of the CSF. So the CSF analysis by lumbar puncture is important for diagnosis of inflammatory and infective conditions of the meninges especially, and also to diagnose subarachnoid hemorrhage by seeing the xanthochromia and the blood-stained CSF. But they are not helpful, the lumbar puncture not helpful in diagnosis of brain tumors. For example, brain tumors, they as a cause of headache, these are neoplastic causes of headache, although they more commonly cause chronic recurrent chronic headache. Acute headache in brain tumor may be related to increase or rapid progression of the side of the tumor, whether primary or secondary, or related to advancing brain edema or sudden hemorrhage inside the tumor. These are usually the mechanisms of acute on chronic headache in patients with intracranial space-occupying lesions, including brain tumors or brain abscess or brain cyst, any intracranial space-occupying lesion. Most commonly tumor, whether primary tumor of the brain, like gliomas and meningiomas, and so on, or pituitary tumors, or secondaries in the brain. Headache is very important acute presentation, or acute on top of chronic. So the neoplastic category and its relation to headache is also important. This is, in short, the types and of headache and the class of headache and how we approach them in clinical practice. Physical examination and the history are very important, and they are usually, they direct the clinician to what further investigations are needed. But of course, number one after physical examination will be fundus exam to detect papilledema and to see the retina for any retinal changes, because we all know that the retina is a window to the brain. The retina is a window to the brain. That's why examination of the eye is important, and not only the retina, the pupils, changes in the pupils of the eye, hemorrhages in the eye, in the conjunctiva or in the sclera, changes in the retina by fundus examination, and the most important retinal sign we see it is the edema of the optic nerve head. We call it papilledema or macular edema, which denotes an intracranial hypertension. That is rise of the pressure inside the skull, which might be related to tumor, as I mentioned, or maybe what we call the pseudotumor cerebri or the idiopathic intracranial hypertension, which is a separate category. So this is important, fundus examination. Then after that we proceed to CT and MRI. These are the next important, and then to lumbar puncture in specific, especially in feverish patients, febrile disease with acute headache and disturbed level of consciousness, if you are suspecting meningitis or encephalitis, or less commonly in patients also with vascular disease, namely subarachnoid hemorrhage, to see the changes in the CSF. And sometimes you have to do the CT in order to, before the lumbar puncture, in order to exclude any intracranial hypertension, because if we do lumbar puncture in anyone with intracranial hypertension, especially acute intracranial hypertension, it might cause cerebral herniation and be fatal. That's why in many patients who are suspected of having intracranial hypertension, especially patients with focal neurological deficits, patients with seizures, or patients with disturbed level of consciousness, we have to do CT before the lumbar puncture. We have to do first CT and then the lumbar puncture to exclude any intracranial hypertension, because if we did lumbar puncture in a patient with recent acute intracranial hypertension, especially patients with edema of the brain, they might get what we call tentorial herniation, which is killing because it compresses the brainstem and may be fatal. So it's important in some cases to do the CT before the lumbar puncture. Although in many cases we can do the lumbar puncture without first doing the CT scan. But especially patients with disturbed level of consciousness, patients with focal neurological deficits, patients with seizure, we have to do first the CT to be sure that there is no intracranial hypertension to avoid any possibility of brain herniation which might be fatal. This is in short what about acute headache in clinical practice and the different possible causes of headache in clinical practice. I will have another smaller presentation as a continuation of this one to collect other smaller topics in acute headache. Thank you so much and have a nice day.